discussion aside for what we call a community conversation. So while all of our other presenters may have slides and research and a particular topic that they're discussing, this is a time for us to just talk. There's so many different types of people in the room, different professions, different perspectives, and there's a lot of value with us just talking about the challenges that we are experiencing, the achievements that we are experiencing, and present opportunities for partners. Because in the midst of all of this, I truly hope that you are networking, collaborating, exchanging cards, and building relationships, because this work that we're promoting here does not happen without relationship. So I want to introduce our participants for this part of the discussion. We have Shawndrika Cook. Y'all have heard from her multiple times today. She's the Director of Clinical Services with the Black Women's Mental Health Institute. She is what makes this go round. So I can't stress that enough. With her, Ashley Shivers, who's a team member who's in another room managing our online participants, and Tiffany Elliott, who's actually taking Dr. Akbar back to her hotel and then to the airport even as we speak. None of this happens without them and our phenomenal interns. Then we have Dr. Carlos Alemán, who's the CEO of the Hispanic Interest Coalition of Alabama. So extremely happy to have you here and to bounce some ideas off of you about what it looks like to do a statewide assessment of Black and Brown populations and the health disparities that they experience. And then Robyn Hyden, who is the Executive Director of Alabama Rise. I would love for y'all to ask her some questions and really engage her. I've mentioned Alabama Rise a couple times already today, and Medicaid and Medicare expansion has come up quite a bit today. She's going to be a valuable resource for that conversation. So I just maybe we should start there, Robyn. Maybe we should start with, because it has come up quite a bit today, the importance of the expansion. Do you mind sharing a little bit about what Alabama Arise does and how you're working in that space and what the community can do to support those efforts?
Thank you for the opportunity. Thanks for having me. Good afternoon. I know you said this is not a place to share research or slides, but I will just share. I know there are a lot of clinicians in here and service providers and nonprofits. So we have a guidebook to what is Medicaid and what does it do in Alabama. And I have a lot of copies that I do not want to take home with me. So I'm going to leave them out on the table outside if you'd like to read it. It has really useful charts and graphs about who gets Alabama Medicaid, who is left out, what is Medicaid trying to do to improve quality. I do think Alabama Rise is a statewide advocacy organization. We're public policy advocacy and organizing, and we are member-led. So our members are churches, nonprofits, civic groups. Together, we think that to fight poverty, we have to address policy. And one of the biggest policies that Alabama has left on the table for more than 10 years now is expanding Medicaid to cover over 300,000 low-income Alabamians with affordable health insurance. I think we've all heard a lot of the discussion already today, and you've educated me a lot over the years about how coverage alone is not enough. There are a lot of systemic barriers that go beyond just having a health insurance card. There's medical racism. There are medical deserts. There are, policies that are well-intentioned that still create barriers to getting good care. So some of what we do at Arise is not just advocating for increased access to care through our Cover Alabama campaign, which I would invite all of y'all to join us today. CoverAlabama.org. You can sign up. You can send an email to the governor. You can contact your lawmakers. You can just learn more about the campaign. We're also trying to improve Medicaid itself. And I want you all to meet Jennifer Harris. Who's our health policy advocate over here at the front in purple. And she's working with Medicaid members to say, what's wrong with the care that you're getting? And address some of the core systemic structural health issues and health inequities in our state that we can address with the system we have. So that's Arise in a nutshell. That's what our Medicaid expansion is doing, is trying to increase access to healthcare. And I'll finish just by saying, if you want to understand why everyone still doesn't have care, even though we have the Affordable Care Act and you can go on healthcare.gov and get health insurance, a lot of people simply just make too little money to get healthcare on healthcare.gov. And y'all, I see y'all nodding like y'all know this. But I also brought this little handout if you need to explain it to somebody. If you make above the poverty line, if you're up in this family of three making over $2,000 a month, that's the poverty line for a family of three. you can get no-cost care pretty much on healthcare.gov. You can get a Blue Cross Silver plan or whatever, and it is good coverage. But as soon as you fall under that poverty line, you fall into a gap where Alabama Medicaid is so restrictive. If you're an adult who's not disabled, who's not pregnant, just a working age adult, you are not going to qualify for Medicaid unless you make very, very low amount of money. 18% of the federal poverty line for a family of 3, that's $373 per month. So you're thinking that's not a survival wage. And that's the problem we've created in Alabama. We have failed to enact well-meaning policy. We've left hundreds of thousands of people in a coverage gap. And immediately, if we think about triaging our state's inequities in healthcare and mental health, getting that coverage gap closed is one of our top priorities. And you can find more information at coveralabama.org to get involved. Thank you.
Thank you so much. We enjoy, I really appreciate being a regular partner with Alabama Rise. So yes, thank you. Carlos, in addition to being one of the coolest guys in Birmingham.
Yes.
You are a part of the Hispanic Interest Coalition, right, of Alabama?
Yes, ma'am.
The research that we're looking to duplicate is a project that was done. It was a statewide assessment in California that looked at the health disparities that exist in the Black and Brown populations there. And it produced a report that elected officials and community members are now using to bring about policy change throughout the state as it relates to healthcare. We're looking to duplicate that here in Alabama, which means we will be reaching out to you at HICA to really get that done and have it impact the entire state. What I'm interested in hearing from you are what are some of the specific health disparities and challenges and barriers that you're seeing in the population that you serve through your organization?
Sure, thank you. First of all, thank you for inviting me. I really appreciate it. I think that when we talk about Latinos, Hispanics, Latina populations in Alabama and really across the country, the barriers that we see are tied to language access, right? Because the truth of the matter is oftentimes we want our folks to be able to receive mental health services, but there aren't enough mental health counselors who speak Spanish.
Mm-hmm.
And then oftentimes I've even had counselors and therapists say, hey, well, why don't we just use a translator or interpreter? And so you're paying just as much as anyone else for half the treatment, oftentimes because of how much it takes to interpret and translate. So we have a desert of just trained bilingual mental health experts and folks that can treat our population. You also have a stigma related to mental health. And so that's a challenge that we face every day. We also have issues around cost and health insurance. We work with a population, and in Alabama in particular, that has all sorts of immigration status issues. They can be citizens, they can be permanent residents, but a lot of the folks that we work with are undocumented. These folks cannot receive insurance, no matter how hard they try. No one will take coverage for them. No one will, and then they can't afford the rates that folks want to charge. And so I think that there is a real gap in trying to get treatment and service. And then you have, of course, just being in Alabama, transportation issues. You have childcare issues. You have criminalization issues. You have law enforcement issues. You have poverty issues. I think that these are all compounded, right? And then you have a sense that counselors or mental health experts, or just the health industry in general, doesn't really want to help you, right? That they see you as a burden because you're requesting materials in Spanish. You're trying to get access to culturally competent and culturally specific folks, and they just don't exist. So those are real challenges that our community faces. And one of the things that we've tried to do and try to figure out is partner with mental health experts who are bilingual so that we can provide low cost efforts. But those efforts are really difficult, right? To find folks that are willing to charge enough for them to make a living, but enough for our folks to be able to afford it, right? I think that those are challenges that we're trying to meet. And these are issues that we see across state. And as you all know, our young people are really struggling. Our young people are really struggling. And then when you compound that with immigration issues, of whether your mom or dad is going to get deported, of whether you are going to be able to go to school. I mean, if you see what's happening in Florida right now, that happened here 10 years ago, y'all. I mean, Alabama, we passed the harshest anti-immigrant law in 2011. And we were able to repeal some of the harshest provisions, but we're seeing this movie play out again. And these are going to have detrimental effects and exacerbate disparities that already exist.
Absolutely, absolutely. I don't know if we've shared this thoroughly enough today, but the Black Women's Mental Health Institute launched a pilot counseling program at the end of last year. It launched in September, October. September, thank you. And at the end of this month, we will have reached 1,000 hours of free counseling, and that's with a program that's only been in existence for about 8 or 9 months. It shows you the excessive need. Thank you. So we do now have clients who are in 32 cities and 13 counties across the state, and it's growing every day. Here's the tricky thing with us. We don't turn anyone away. So even though we're the Black Women's Mental Health Institute, we acknowledge that Alabama continues back to back to rank 50th in the Mental Health America Mental Health Access to Care report. So since we are 50th, we don't turn everyone away. That means a lot of our clients are not Black and some of them are not women. We are now in the process of trying to recruit Spanish-speaking clinicians because the need is so dire, it is so great. So we will be collaborating with HICA to really advance that, because when clients come to us, they can get free counseling, and at this time, it's roughly a 5 to 7 day turnaround to get them services, which is also a bit unprecedented. So thank you for sharing that, absolutely. Shawndrika. You pretty much built the map for our counseling program that has an internship program built into it. We've heard quite a bit about how hard it is to find a clinician of color, but also a clinician that's culturally responsive, so trained in cultural competency. Specifically as it relates to Black clinicians, it's 2% psychiatrists, 4% psychologists, roughly 7% LPCs, 4% LMFTs, very, very low numbers, right? So we're working to increase that by having some of our phenomenal interns who are doing that work and supporting them through full licensure. So when you see the young people in the back, when you see Megan back in the back helping the stream team, and you see our other interns floating about, these are the individuals who we're looking to support to increase the diversity in these in the field of mental health. The reason you are so passionate about it is because you understand thoroughly the roadmap to licensure, as well as the barriers that exist that prevent Black and Brown individuals to persevere to full licensure. Can you share some of those things, as well as what your recommendations would be to kind of remove those barriers?
Yeah, so thank y'all so much for being here. We're so excited that you all are here. When Nadia asked the question, or when she was saying, well, Shawndrika, can you talk about this? I was just thinking about my own journey as a clinician. And one of my classmates is here. Naisha is here, or she was here. She and I went through this program where we were the only 2 Black students at school. And we looked, and she was just saying to me, she's like, Shawndrika, remember when we dreamed about this? So y'all, that was just in 2011 that we were dreaming about this ability to have access to have the network to provide space for clinicians of color. So 3 things that came with that process. One was the fact that it costs a hell of a lot to be a clinician. We're not even just talking about grad school. We're talking about, okay, so you got to do this application, this associate application, where you're an LMFT or you want to be an LPC. You have to do this application on top of paying for this test. And if you flop this test, you got to take it again, right? And that starts to add up on top of supervision. And so I remember being in a board meeting, an ABAC board meeting. And in the board meeting, one of the students said, what do you do about supervision when your supervisor is charging you $200 a week for supervision? $200, sir, ma'am, I just paid your house off by the time, because it is projected that it would take me 3 years to get to these 3,000 hours, right? So for 3 years of my life, I paid $200, 52 weeks. Y'all do the math, that started to add up, right? And so when we were talking about this project, when Nadia brought this to me, I said, Nadia, first, we got to figure out a way to pay these people, or give them an expansion of where we're paying for some of those fees, because that can be overwhelming. First, I got to figure out how to get these hours. Then I got to interview a supervisor who wants me to be on their team. Then I got to find a supervisor that's culturally competent or competent enough to be passionate about what I want to be passionate about. Then I got to figure out how to make these theories that are white driven to make them towards black people or brown people. And then I got to make sure I'm confident and I don't get imposter syndrome while I'm doing it. Do y'all see what I'm working with? And then I'm a sister, so I got to make sure I call it the black girl check. I got to make sure I'm calm. I got to make sure my face is straight. I got to make sure that my body language is okay, because I don't want to come off offensive in my passion of telling my client, you dumb as hell. Right? And you don't say it. You don't say that out loud, but in your mind, you say it. And Nadia says, I have to learn how to fix my face, because even though I don't say you dumb as hell, my face said it, right? And so we have to be culturally aware of all of that. Do you know those are all barriers? That I have to step in a room where I cannot be my authentic self? Do you know that there are policies right now? And I just told Nadia, I'm in a state association and I have to deal with policies within that state association to make sure that I have room for Black and brown clinicians. So I started a fellowship within that space. Do you know they asked me to compromise that fellowship? So what do you do when you are part of the multicultural division that asked you to compromise the fellowship? It's multicultural. I don't have to invite, no offense, my white colleagues, because we don't have a space. 2020 was the open key for us to say, hey, wake up. Because nobody asked a Black clinician who had to deal with the trauma of other people, is their clinician okay? And so when we built this, I wanted to be a space where my Black graduate students felt comfortable enough to ask those crazy questions, that can deal with those imposter syndrome moments, that can deal with those moments where they felt inadequate in the classroom, right? And they felt like they knew those theories, but they knew them in their own language, right? And a lot of times what happens is you are penalized for translating what is white into your language to translate to your community. And so we wanted to make sure that happened in our program. So it wasn't about, do you know the Illyrian theory? Because it's my favorite theory, because they do drama and I'm dramatic, as y'all can tell. It wasn't about that. It was about, can you translate that and be confident in that? Can you translate the fact that you can explain to a client that, so you are dealing with depression, but your depression is based upon racial trauma and not just trauma. Not just the fact that your mama and daddy did it, but that you was at this white school and they painted you the token, right? And that was traumatic, even though it looked like it was glorified. How do you do that? So that's what we decided to do in this.
So you can see now why she's the mastermind behind our program, because she's taken all of that passion and put it into policy and procedure, and has outlined an internship program that creates affinity spaces. And we know that affinity spaces are so important and so necessary and so needed. But now we pay our interns. So these thousands of hours of internship time that they need to complete in order to complete practicums and work towards licensure, those are usually unpaid hours. We pay our interns. We find that to be equitable, right? If we're going to say we're truly about equity and social justice and healing justice, we can't expect individuals to put those kind of hours in and not be able to pay them. And then for them to have to put those hours in and get part-time jobs and then take classes, we're basically setting them up for burnout. And we also provide them with free supervision. So now you don't have to go pay for supervision. You can get that from us. And now you don't have to go find clients to fulfill those hours. We'll provide you with clients. So it really is a program that is working to support interns, but also provide those services directly to the community. So You see where it came from. All right, so I'm gonna close this. We're done. Now, this is a conversation, right? It's community conversations. What do y'all want to talk about? What is important? What is pressing? What have you heard here today that you feel like we need to dive into a little bit more? Put it out there. Let's have some conversation with these phenomenal panelists. Yes.
I have a question about servicing our Latinx community. So I have a therapist on my team who is a male bilingual therapist who is Mexican. And so we get referrals, but he has a full-time job. So at least for the next 2 years. And so one of the things that we're struggling with is that I'm translating all these documents so that I can be culturally responsive and make sure that what I'm offering to the clients is equitable, right? So from the moment they come in to receive services, that they can understand things. But the problem that we're running into is being able to find access to mental health literature that allows us to walk them through therapy, right? And also when he doesn't have the availability, being able to send them to a resource where even if they don't have a therapist, there's some sort of mental health support. So how can a clinician like me have assistance in helping that community that we're serving? Because I'm not bilingual and I have very limited understanding, but I'm the person that's running the practice and trying to pretty much make sure that I'm providing those resources.
Sure. I mean, that's a great question. I think that's the current challenge that we're all facing, right? I think that's a project that we can all work to try to solve for, right? I think that's a real issue. Even finding talented translators and interpreters that can, modify your documentation to be more accessible is a real challenge that we're trying to work towards. We don't at HICA do translation interpretations because that's all we would do all day if that's what we committed to. But we have partners that can help with that. Now, finding resources. I know Nadia works with my wife also.
Yes.
And she's a researcher at Alabama. And she's working around some programming to work with young Latina adolescents around sexual health, right? It's not necessarily mental health, but we're trying to figure some stuff out and creating more materials, right? So I'll reach out to her because she's going to be more knowledgeable around those. But those are real issues. Right now, I'll give you an example. My wife and I entered marriage counseling, right? Trying to, make sure that the marriage stays strong. We wanted to find someone who was Latino, right? We couldn't find anybody. And we're real picky and selective, and we wanted to make sure that someone understood our cultural values, our family values. She's Puerto Rican, I'm Nicaraguan. I'm gonna say that again. She's Puerto Rican, and so I had to make sure.
I'm glad Dr. Alpark is gone, because she would have got you together.
But we wanted to make sure that we had someone who could be responsive to our particular values, right? And it was really difficult, and so. We have been wanting to do this for about 5 years. We hadn't done it before because we couldn't find some. We interviewed folks and we're like, that ain't the one. They don't understand, right? And so I think that even language-wise, cultural-wise, I think that there's a lot of need, and we need more people. We need to train them up. We need to encourage young folks at the schools to get these programs and get these certifications. But I want to be a partner to you and trying to figure out, but I don't have the answer.
So I do have a question for you. What's the hesitation of the collaboration of Black and Brown people? What do you feel like there's a hesitation is?
I think that goes both ways, right?
Okay.
I'll be honest, right? I think that, we are really intentional at HICA of trying to build partnerships between Black and Brown communities, right? But I think there's a lot of misunderstanding. There's a lot of scarcity mindset from population say, like, if they get something, we don't get something. Right. I think that we have to recognize the historical legacies that Black folks have faced and honor and respect that. Right. And I think sometimes there's hesitations around that and talking to our folks about that. There's, of course, racism in the Latino community. There's anti-Blackness in the Latino community that we have to address and work on. And then from the other side, what happens when, we're in Alabama and to be Latino in Alabama is to be invisible because the conversation around race is only Black and white. Right.
Yeah.
And so like when I walk into a room, I'm almost always the only one that said, is any of this in Spanish? No. Have we talked about what are you doing about social security numbers? Are you asking people for their tax ID numbers? Are we making this accessible for folks that may not look like you? Right. And so those are real barriers that still exist. And there needs to be greater efforts at understanding, right? Because our struggles are not the same, but they run parallel.
Yeah.
Right. And I think that we're facing struggles around poverty. We're facing struggles around living in white systems.
Mm-hmm.
Right. And so while we may not be Black, we sure as hell ain't white either.
Right.
And so I think that those are real issues, right? Because we're still otherized, we're still racialized, right? Latino is not a race. I want to put that out there also.
Mm-hmm.
So we can be Black, white, indigenous, and every mixture there, and Asian, what have you. We are a ethnicity, right? And that's an imperfect pan-ethnic label, because you're going to have our brothers and sisters from the Caribbean have very different experience from the people that come from Chile and Colombia, right? And so we have to recognize the heterogeneity that exists there, and those historical and racial legacies from those countries impact their perspectives when they come to the United States. And some of those folks who are white, actually, some of them, right, who come from South America, are confused when they get here, and they're not treated as such. And so I think that we have to address those legacies as well and create understanding, right? I mean, honoring also the fact that a lot of Latinos are Black. I mean, they're Afro-Latino, right? And so how do you carry multiple identities? So I think that there is a divide, but I think there's work that we can do to create greater understanding.
Absolutely. And I do see pushing past, I had this conversation recently, pushing past that scarcity mindset means that you take the focus off of individual differences and disagreements and really look at the systemic issues that are contributing to those misunderstandings, right? And at the root of them, at the end of the day, it's white supremacy as to why oftentimes Black and brown populations are pinned to seem as though they're competing against each other, when it's really not. It's really we are acknowledging that we're engaging systems, systemic racism in our healthcare, education, transportation, housing, all of those things. We should be focused on that than looking at each other as though we're competition.
And I think we're forced to compete for the same limited resources, right? So when white folks get 70% something and Black folks get 30% something, they want Latinos to come in and say, you got to get that within that 30%. We're not growing this piece, right? And so I think that's what we need to work together. And I think there's opportunities to collaborate and say, let's grow this, right? And have an abundance mindset.
Absolutely, I love that. Okay, yes.
Thank y'all. I really feel like this whole thing is so awesome. So one thing that came to mind, you spoke to it earlier about the cultural differences, and I think there's a value as clinicians and therapists for us to understand the diversity of our society, and even the diversity that is within this room, and how we protect and maintain that. Because when we deny the diversity, we are denying the individual that embodies something different. And so it takes away from that person as an individual, and then you put them into some category. I think there's a value that we, as those who are part of the system for helping, need to have our own moments where we understand what's really happening in this society, where the diversity of what makes America beautiful is not really melting into something. I don't need to melt into anything. I'm good as I am, and so is everyone else. The other part of it is, I think that we have a value and a duty to affirm people's humanity when we get faced with helping and serving. Just like Dr. Akbar, she talked about the person with all of these things, and it turned out to be her. Someone affirmed her humanity. And I'm a LMSW, and I go to these amazing conferences, right? And there's very few people of color in the room. And then I look at the agenda of what we're to be learning at these conferences that we pay for to validate our CEUs and all of these things. And very few of that information is really valid for us as people of color, for the truth of the people that we're serving. And I think that we have a duty also to take action. We really do, because we have the power to do so, but sometimes what we are lacking is maybe the collective process. I don't know. But I would like to be a part of that, and I would like to see it happening, especially when mental health workers, who are some vital to our society.
So I just want to say, Dr. Nadia and I were on a conversation. We were on this conversation and we looked at this conversation and we were like, something not right about this conversation. And it was a space that once felt safe was now whitewashed. And we had a conversation afterwards. I was like, girl, what are we supposed to do with this space? Because this space was a representation of policies and procedures, a representation of conversation. And in this representation, this was a whitewashed panel who serves people of color, but there was nobody reflecting who they served. And I think a lot of times what happens is safety. I always tell her about safety. There's safety in having people who feel safe, but may not know the actual information. So it's safe for me to do the Black girl checklist, but it's not safe for you to check yourself for making me do the Black girl checklist. Does that make sense? And so that's a frustration I have to internalize, swallow, and keep moving forward. So I now have to dim my light to feel safe for somebody else. And so that's the reason why there's a lack of collaboration. It's because nobody says, are you feeling safe? I'm always making sure they feel safe. Does that make sense? And so that's the problem. There's a safety issue, right? And when we have safety issues, guess what? My guard is up and I can't be my full authentic self. The reason why this space is so important is because even though she's right here, I hope that we make anyone who is an ally or white feel safe in this Black space. However, if the shoe was on the other foot, can I be honest? I wouldn't feel safe. I would be looking for the safe white ally person. I would look for the person who I felt would be safe enough to come speak to me. And I can be semi my authentic self, but that's not always given. It's not, you'll never say, hey, are you feeling safe today in this space? Because you feel uncomfortable. The one thing we ask as people of color is ask the question. We're good with asking the question. It's not that we would be offended. We're offended when you don't ask the question and draw the conclusion. And that's the thing. That's the reason why there's lack of collaboration. There's a fear of asking those hard questions. Hey, I got a question. Our intern Megan asked a question, right? She asked me a question. She's like, okay, Shawndrika, I really want to ask this question. But I want to make sure I'm culturally competent. And she literally built up before she answered this question. And I was like, Megan, we literally create a space for you to be safe. Girl, if you don't ask this question, right? Ask this question, whatever it may be. She's like, well, I don't want to offend anybody. And even in her interview, she's like, I have a colleague, her name is Jade Lee. And we was like, we ain't asking about Jade, we asking about you. Because she, and her one thing she kept saying was, I don't want to take away from a Black woman. I was like, you won't. You don't have the decision. Nothing you will say will take away from her space. Right? Be you. We'll create the safe space if you create the safe space back. That's not an equal exchange in that safety.
Thank you so much. An example of what that looks like for us is, again, this is the 7th year we hosted this event. When we launched it initially, it was there are a couple reasons. The U.S. Senate in 2008 designated July as Minority Mental Health Awareness Month. So for the first few years of hosting it was the Minority Mental Health Awareness Summit. However, we've moved away from the use of the word minority and really looked at the content of what we were talking about. And we're like, you know what, this is about equity and this is about liberation. And liberation is about freedom. And if you need to be free, then you have to acknowledge that you've been oppressed, right? So this is why we kind of changed the structure of this event. Another reason why we started it is because there were so many mental health conferences, because we like to go to them, right? That would be completely white. Every single speaker would be completely white. And this is years ago, right? At least a decade or so ago that this kept happening. And I was like, that's ridiculous. And another thing in regards to diversity, sometimes it's cognitive diversity, right? Making sure you have different voices in the room. If everyone is a PhD or an MD, that's not diversity. If you're talking about mental health, you need community partners, right? You need to have caregivers. You need to have people with lived experiences who are managing mental health concerns, who are speaking on these podiums. If it's just doctors, then we're just talking to each other about what we learned in school. But if you have community partners here, they're talking about what's happening in the world and then making the research applicable and accessible to the people, right? So it can inform programs. That's a different approach. But guess what? A decade later, we're still seeing it, right? We're still seeing panels of all white. And at this point for us in 2023, it showcases a lack of innovation and dynamism and commitment. At this point, there should be no excuse for anyone to host an all-white event. We could have easily done an all-Black event, but guess what? There are so many Black mental health conferences that already exist, and they are done and done well. So we decided to go the route of creating an allyship opportunity. So even though this is a Black Women's Mental Health Institute, not all of our speakers are going to be Black, because we want to talk about equity and mental health disparities across all forms of difference, right? So we were intentional about it. But guess what? And the first time we put a call out for programs, every submission was Black. We were like, I thought we communicated that this is not an all-Black event, but maybe it's because of our name or maybe who we are, that this is what it is. And so we were put out another call, all Black. It's like, okay, we're not getting this. So guess what we had to do? Intentional. We had to reach out, make calls, call organizations, research other people who are speaking about this from Indigenous perspectives, from AAPI perspectives, from Hispanic perspectives, and invite them, and let them know this is space that we're creating for everyone. But the all white spaces keep happening. Now, I'm an educator, so I believe in calling in versus calling out, right? Because I believe that that's how collaboration and partnership happens. So one of our community partners did recently host an all-white event. They hosted a conference, we're partners, so it was sent to us, and I was like, oh my gosh, I love the support, whatever. When I saw it was all white, I was honest. Take up space and speak forward. I was like, I don't think that we can effectively, so we can't promote this. And then it was disheartening because you're a partner, and this is happening. And so I called a conversation, had the discussion, and guess what? It was productive. I didn't say, well, you're racist and this is happening and blah. It was not that at all. It was out of love. It was out of commitment, because this partner has already shown their commitment to the work that we're doing. And so it was an oversight. That oversight happens because of what? Implicit bias. Sometimes we stay in our own network. If we had stayed in our own network, this would all be an all Black event. But we have to move outside of our network and be intentional to invite people to be here, because these conversations are conversations that everyone should be having. So a lot of what you're saying is that's it in action. It's intentionality, it's partnership, it's learning from each other, it's increasing accessibility, because change is not going to happen in our silos. It's just not going to happen. We have to work. It's going to take collective effort and energy and partnership to bring about the changes. That means if you're a doctor, you need to be working with a licensed professional counselor. If you're a licensed professional counselor and you don't know the pastors in your community, what are you really doing? You know what I'm saying? Like, if you are a teacher, how are you partnering with nonprofit organizations? Everyone in this room should walk away with an understanding of Alabama Rise and understanding the HICA. So if you're not following them online, you should be doing that now. If you are not familiar with their websites and their programs, you should do that now. And if you're interested in any volunteer work, you should reach out to them and do that now, because the work that they're doing in the state is important and invaluable, and they need everyone's voice. I saw a hand up in the back. We're gonna wrap shortly. Actually, there's one behind you, then there's you. We're gonna wrap shortly. We're not going to have much of a break. I know we fell behind a little bit, and I want to make sure that we respect and include enough time for our next speaker to present. But there's a hand, I believe, from our OAA representative. I'm so happy that you're here. Yes, please.
I'm so happy to be in this space and bring some diversity and equity. We're community partners. We're not clinicians. We're violence intervention specialists. The street all our programs from the street. So we talk to a different demographic.
lost his train of thought.
So the question is though, our load of vicarious trauma is exponentially increasing because we deal with a lot of uninsured, particularly as far as gun violence survivors are concerned, the mothers of at-risk youth who feel like they're 0-3 because one son's been murdered, one son's incarcerated, one son's in trouble. We have difficulty as case managers referring to services that can do more than a 1 or 2 session type of a deal. And to have, because ongoing treatment is needed, all right, and we recognize this. So when we saw women's mental health, we wanted to jump on that because it's one of the hardest parts of our job with the family engagement component. Because we don't know we don't have the toolkit to handle this, and we don't know who to refer because all of the mental health professionals have to earn a living. So, and with the problem with Medicaid and qualifying and whatnot, we don't know who to refer to. So we're looking for allies for referrals for these ladies who are in ultimate urgent trauma.
So I'm hearing the question is, how do we refer? How do we connect? And what do we say? So can I say that when you're talking about a mother who's lost a child to gun violence, you're looking at a mother in 3 different aspects. You're looking at a person who's grieving but got to keep pressing. You're looking at a person who failed but got to pick up the pieces. And then you're looking at somebody who may be from a generation that just knows how to press on and pray. So so for you to say, hey, you need to go to therapy, that in itself, depending on generation, may be a trauma added to the trauma that she already dealing with. Then you may be finding yourself triggering her grief. Right? Because and it may not be the grief of the child she lost, it may be the grief of the child she lost, which is her. So you're asking her to go to counseling to grieve the loss of the child she gave birth to while also grieving the child of who she was. That's too much. And so that's why you hear no. And that's why you hear I'll do it later. And so what you have to do is now incorporate an introduction. Let's do some group counseling. So I need to know I'm not in this by myself. I need to hear somebody else's story. Maybe if I hear somebody else's story, I'll feel as though I'm adequate enough to be in this space. Because at this point, I don't have no value. I'm just floating through the world. I'm just trying to keep my head above waters, right? So I'm speaking to myself. I may be suicidal. I may be depressed. I may have anxiety. But I can't show that because, one, I'm still a Black woman. Or I'm still a woman, period. Whether I'm a Latinx, white, whatever, I'm still a woman. And I got to keep pressing because it's expected that I do so. So there's another level. There's a world expectation on top of this. And so my suggestion to you is create a collaboration of group therapy. Start with the group. When you're dealing with that type of trauma, group is first. Then say, hey, we offer individual. But if you don't invest, if they don't invest in the group, they're not going to invest in the individual.
Thank you. So we had another hand. Hi.
I just wanted to say, thank you for letting children about that here today. Just to make the story full circle, I think I can be transparent and vulnerable with you guys. The conference that they were referring to was one that we had in Alabama yesterday. And so I'm here to say that our partnership, which did exist prior to that, has been a very strong partnership and continues to be so. But Nadia has really helped me in the team that I work with at Children's to be able and now that's going to change some things. And so I just want to say, I appreciate you did that because it was received that way. And we really do have a responsibility to have cultural humility and to have understanding and to really do the work, like you said, increase our own awareness, talk ourselves to think twice. It is easy sometimes, and y'all know this already, for people just to invite, and using, as you said, using your circle. And that is something that does have to change. So I just wanted to go full circle with that story. Thank you for sharing that, Shawndrika. I'm sort of the face of a learning experience, so I can be a witness today to having experienced something in conjunction with you guys that has really changed things.
Cindy, I absolutely appreciate you. You
Yeah.
did not have to stand up. I was not gonna be like children. Like, I was not gonna do that. But the fact that you stood up, I think, shows your authenticity. The conversation that we had when this came up was what it was. I shared how I felt. I shared that it wouldn't be a good look for our organization. It's not reflective of our commitment to diversity. And you received it. I also said, next time y'all are putting that together, put me on the committee, and I will support you kind of in putting those things into action and making those events more diverse. So you did not have to stand up and say that. So thank you for doing that and being so transparent. So here's the thing. We're navigating this moment. Our 245 speaker has not shown up and she has not responded to email. She is a professor and also a doctor at UAB, so I'm trying to navigate whether something may have come up on our schedule. But this is fruitful. Are y'all enjoying this? Yes. So what I may do right now is step away and ask Lauren if she can kind of continue moderating. Did that face? I'm sorry, Shad. I mean, you're so good at it.
Y'all remember that imposter syndrome?
It's right here. Like, you were on it. You got it. And I will step back in as soon as I try to find out where she is. Let's just wait. It's just fun. Do we have another question?
Yes.
Another comment? Another conversation we can kick off? Here we got a couple. Here.
You know, I worked with a great social worker at my last job, who was a white young lady. And I remember us laughing about, apparently there was some background on Facebook where you could look up how they categorize you. And because of the things she was interested in, they had her identify as a Black female Democrat, which was hilarious to us because she was a young white woman who was raised in Mountain Brook. And we just talked about how much of an ally she was and how to create a space within our program. Because even though I was her supervisor, when we would go many places, we would show up and people would assume that she was my boss, although she was much younger than me. And so how she navigated that and how we were able to address, differences created this really good working relationship. And one of the conversations that we had was, how do we mirror this dynamic that we've been able to create where you can come and say, hey, one of the girls, because we primarily serve girls of color, and they would say things to her and she would be like, is this a Black thing? Like, I really have no idea what they're talking about, right? And so how can we create these dynamics in these spaces where different women of color or different people of color are able to come in and ask those difficult questions? What have you guys done within your program to create that space, and how can we as clinicians replicate that?
So, you asking? I'll go first. No, Carlos, you go first.
I'm gonna be honest right now. HICA, everyone's Latino, so and to be honest, that's mostly been intentional, right? Because oftentimes the issue that we encounter and face from other folks that, well, where do you find people? There's no one who could hire. Because we always tell people you should hire someone who's bilingual. Where do I find them? I'm like, I got 32 people. I found every single one, and they're all here in Alabama. And so at the same time, in community spaces, we try to create spaces where we can have these sorts of conversations, right? I think that you have to be be willing to be vulnerable, right? I think that was really reflective of that, and create that space where you're not going to attack someone for saying necessarily the wrong thing, right? And so when we have these conversations around immigration, for example, right, around race, I try to be as
hopefully not safe. Are you safe?
No, graceful.
Oh, okay.
Right, like I like to give grace, right? And so I think that I try to be as open in that space, right? Because I think that instead of safe spaces, we need courageous spaces.
That's good.
Right. And so I think that's the challenge, right? How do you create a space where people can be courageous and you can have a back and forth and have real conversations, to your point?
But also, I'm going to add to that. I don't want to be so courageous that I'm educating you.
Facts. Yeah.
right? Like I want it to be equal exchange, but I do want to learn. Like if you say this, you ain't got to educate me, but can I translate that in black language? Like help me understand what that means. And I always tell white clinicians, there are certain things in the black culture, and it's probably in your culture as well. I can say a whole sentence with my face. One word can be a whole girl. And here's the crazy thing: every woman in this room interpret exactly what that meant. And based upon our tone of girl, will create a thing. And I feel like that's in any culture of color. Like we have our own nonverbal verbal communication, and you can't teach me that. Right? Even if I want to say, if I say, Carlos, oh my gosh, I really want to work with the Hispanic population. I really want to learn bilingual. I really want to, I really want to be immersed in the culture. You're gonna be like, okay, Shawndrika, that's great.
Yeah.
But there are certain things still that I'll be inadequate in, right? And so I think a lot of times, Tiffany, going back to what you're saying, that's great that y'all had that conversation. And even with Megan, we teach her that, right? And that's great. But not everybody's open to that or comfortable or courageous to be in that space. That takes courage to be in a space where you asking those questions and not wanting to be educated, but wanting to be knowledge of. That makes sense. So I think that's that. I do have a question for you.
Yes.
So as you are talking about the expansion of Medicare and you're getting us there, the one thing as clinicians that we have issue with is paperwork.
Yeah.
That documentation. What are we doing? And that's actually a barrier because it's not that we don't want to be part of that network. It's the barrier in the obligations of, oh, my license on the line. Oh, I'm gonna pay this money back because I made one mistake. And and I corrected the mistake, but I still got to pay the money back. So I guess the one thing for me is, what are we doing with that barrier? Because I don't think it's just, oh, I don't want to do it. I think it's also a barrier of so much liability and being part of really being part of it. It's not just the liability of seeing them, because I don't mind seeing you. I don't mind. There are some clinicians that say, okay, I don't mind getting paid at low cost in order to meet their need. It's the liability that comes with that cost.
Yeah. Well, I do appreciate that feedback. I mean, one of the things Jennifer and I were hearing earlier on the panel with the doctors was that is an issue that we should address administratively with Medicaid. We don't need the legislature to pass a law to make the paperwork easier to, the federal government wants to make it easier for more folks to get Medicaid in Alabama. At least this administration does, right? So the biggest successes we've had as advocates is things where we just go to the agency directly and say, why? We've heard this from providers. We heard this from you today. What is the deal? What can we do what has North Carolina done? Why does Mississippi has twice as many providers as Alabama does? I'm not saying they do. They probably don't. But,
but they did move up, y'all. They weren't at 51 with us. Now they're at 42. I'm just saying.
Well, I mean, that's motivating.
Yes.
No, but yeah. And, one thing we keep as one of our principles in developing policy is, if the people most directly impacted on the front lines of implementing the policy, of benefiting from the policy, of making use of the policy, tell us that something's wrong with it, we've got to trust that they know. And y'all know if you as a provider want to take Medicaid and you're not doing it, please let us know what we could advocate for with the agency, because we have a network of providers who meet with Medicaid. In fact, there's a whole unwinding process going on right now where we don't want to be one of the states where we're just dropping people left and right. What could we do to help you and your clients stay enrolled on Medicaid? What could we do to help you be able to accept Medicaid? We'd love to know that and help out.
So for all the clinicians who thought about it,
yeah,
what is the thing? I know responsibility has been always the one. Go ahead.
The application is so tedious, and then we have to wait 6 to 8 weeks for a decision.
Mm-hmm.
And then, of course, you have to have a site. So they have to come out and look at your site, make sure it's, a brick and mortar. Yeah.
And then, do you know what a client could do to themselves harmfully in 6 to 8 weeks?
Yeah.
I'm to the point where somebody will be like, do you take Medicaid? And I'm like, no, but I'll take your Medicaid rate if that's what you can afford, because then they can come in right then and there.
Yeah.
It's so long and it's so tedious, and there is no guarantee that you're gonna be an approved Medicaid provider.
Mhm.
And they do a very poor job explaining things that are, when you make an error on the application, they do a very poor job of explaining what needs to be corrected. So I think that is important as well. Even if you explain how to complete it, if I send something in that's an error, sometimes they'll just send the application back and just say, hey, you need to correct this you need to correct this form. Okay, well, what if I didn't complete it correctly, then what on the form needs to be corrected? And so a lot of times you have to call or have to email back and forth to just get clarity surrounding what you need to do to correct the things that they're requesting.
Mm.
And by that time, you're just like,
I'm done.
forget it.
Yeah.
Some policies we've looked at as well about making it just easier for that client to come in and you presume that they're eligible. That's a policy that our state could adopt more widely. So we presume that because you're eligible for other services like SNAP, like TANF, like WIC, you should automatically know this patient can get Medicaid. So I do think we have a lot of work to do to streamline and improve the agency. There's no argument there. Yeah. I just wanted to say thank you for the gift you shared earlier of the question that white women should be able to ask, or white people should be able to ask, which is, do you feel safe in this space? Because that's a gift that I feel like I need to use, and I hope more people will start using it. And I heard your, loud and clear, you don't want to be the one calling up the panel and saying, where's all the other Black folks on the panel? So I think that's one thing that I'm going to take as well, that I hope we as allies can take too, is, hey, like, we can be the ones asking that question. Like, you don't need to walk in the room and feel like you have to be the one to ask that question. But thank you for that. Do you feel safe question? So nobody's ever asked you that in a space. Okay.
And I went to PWIs my whole life. Nobody's ever asked me that. And I've been the only chocolate drop in the room and look like, okay, who's safe? Who's safe? She looks safe. Let me go sit by her. Right? So yeah.
And let's bring up how we feel safe in a space like that. It is from macroaggressions and microaggressions of people not of color taking on mannerisms that they think we have to make us feel safe. Oh, I love your hair. No, you don't. You can get these braids, scalp guppies, so that. No, you don't. Oh, yeah, girl, don't do it. Because I don't speak like that, and I'm a Black woman. So it's those things too.
Any more questions? Now all these folks in the world. Okay, yes, ma'am.
Okay, first, I would say a lot of times I tell people I want their long, braided, gorgeous hair, and I do love it. And
Yes.
And I am curious as to how, when you're in a space where you might be with your Black women, how you decide to see the same person to talk to.
Ooh. If I was in a space and I took all the sisters and the brothers, including you, out of the space, and it was just me and all the awesome white women in this room, I would look at the one who approached me first, who said good morning to me first. You would be safe to me. The one who smiled at me, the one who didn't clutch their purse or turn their back and look the other way and try to start a conversation. Because I've seen that. And I'll be like, well, this is on the seat, so I'm gonna have to sit here anyway. So, and here's the thing, I code switch at that moment. I code switch at that moment. And not just code switch in my conversation, I code switch in my whole demeanor.
Can you define what code switch is?
So code switching can be defined in so many ways because we do it even among each other. If I knew he was Dr. Carlos, I would have not spoke to him the way I did earlier today.
Hey, it was well received.
Because I was like, hey, what's up? I remember you. If he was Dr. Carlos, I would have been like, hi, good morning, Dr. Carlos. It is so awesome to hear. Are you a speaker here on the panel? That is not what I did to him. That is not what I did. Right? So code switching is not always not being your authentic self. It's creating safety or being acceptable based upon world standards. Right? So it's not about you not being your authentic self. It's being enough that you are approachable. Right? I'll give you the prime example. If I came in here, I don't know your name, but I'm gonna pick on you, sis. Okay. So this sis right here with this big, pretty hair, dark skinned sister, she would have to be safe for a white woman sometimes. That big hair says, ooh, she's very aggressive. And so she may open her mouth because she saw the look and say, hi, good morning, awesome. That is so awesome. Hi, my name is such and such, right? Because I got to kill the pre-notion of what you think I'm going to be, right? Because you saw me as a dark-skinned Black woman with big hair, right? There's always, before I even open my mouth, there's always a perceived notion of who I am. There's always a profile identity. So in order to kill that, I'll switch so I can make me feel safe and you feel safe. So it won't be no problems, okay?
And code switching is often informed by ideologies that are inequitable, and that impacts someone's perception of someone else. So thank you so much. Our next speaker has arrived, so we're going to usher her on in. Thank you so much to this panel. This was a great conversation, and to the questions that were shared. What we're going to end up doing is not necessarily taking a break. We're going to have the next speaker come in. She's going to shorten her presentation, and then we'll go into the closing discussion. So thank you so much for your patience. It has not yet been shared, but there is a reception afterwards. I believe you got that information by email. So please stay. We encourage you to stay. We encourage you to network. We also encourage you to please eat all of this food that we ordered, because we want to take it home. And it's good. You know, you'll have some fish, chicken, shrimp options. So stay and basically have dinner with us. Okay? We're going to set up for the next speaker now. Thank you.